we start?
Yes, please.
Yes, Dr. Rayyan, please.
As I mentioned before, I've recorded this lecture before because of the circumstances I'm in. So I'm going to play that lecture. Hopefully it should go fine. If there's any problem, do let me know. I have the presentation ready and I'll take over otherwise. So I'll just screen share and I'll start my lecture, which I already recorded yesterday.
All right, great.
Sorry, Rayyan, we can see the slides, but we can't hear you.
The volume of this video.
That's fine. That's fine. I'll take over. I'll do the presentation myself. That's all right. Thank you. Okay, guys, can you hear me? I'll just do the presentation myself because I think the video volume is not sufficient. Is it all right this way?
Yes, we can hear you so very clear now.
That's great. I'm just going to start from the beginning. I'll stick there. Bismillahirrahmanirrahim. All right, everybody. My name is Dr. Rayyan Parvez. I'm a consultant radiologist at the Salisbury NHS Trust. And the talk I'm going to give today is about how to read a pain scan. This is in particular relation to radiculopathy or pain related to the spine, particularly the lumbar spine. So before we start, the most important thing is determining the level at which the patient's symptoms is happening, because if you want to do a procedure or even surgery, you should know the exact level at which the patient is experiencing the symptoms from. And basically a never event or an event that should never happen is when you try to do a procedure at a level where for example, if you have changes at L3-L4 and you end up operating at L4-L5, so that is unforgivable and that is a never event. And before you do that, determining the level is very important. In an ideal world, you could have a scan of the entire spine, and this makes it quite simple because it's easy to measure all the levels you have starting from C2 or the conical top of the spine. You can count down to the 7 cervical vertebrae, the 12 thoracic vertebral bodies, and then the 5 lumbar vertebrae. So interestingly, in this particular scan, you can see that normally if you just had the lumbar spine,
Sorry, Dr. Rayyan, we can't see your slides. Sorry for interruption.
You can't see the slides, can you?
Yes, please.
I had shared it. Sorry, let me get back to this. This is all. Screen share.
Just unshare and share it again, and it'll maybe work.
Yeah, I've shared it again. Can you see the slides now?
Yes, we can.
Okay, perfect. Just interrupt me if something goes wrong. I'm sorry about that. I'll take it from the top again. Sorry about that. Um, so you can see the slides now, right?
Yes, we can see the slides.
Okay, great. So we're talking about determining the level so that the treatment can be guided to exactly where the patient needs treatment from. And this is where we started from, that in an ideal world, you might have the whole spinal MR, and there are certain MRs, particularly the new ones, which can do this for you. So this is the most certain way of counting the number of vertebral bodies. So you have the conical top of C2. You can count the 7 cervical vertebral bodies, then the 12 thoracic vertebral bodies, and then the 5 lumbar spinal vertebral bodies. Now, interestingly, in this case, had you just the lumbar spine, it would be a challenge where most people might have decided that the last vertebral body, many people presume it to be L5, and that is a vertebral body above the level of the last properly formed disc. But as you can see, if you do the proper counting, the last vertebral body is actually an S1. So we'll get on later to this. What are the other means by which we can decide whether there is lumbarization or sacralization at the lumbosacral junction? The other way to go about this is, if you have radiographs, they're always useful. You should always have a complete look at the imaging that is available to you. So again, what happens is you might have a cervical spine and then a thoracic spine, and mostly these are done separately. One of the easy ways is to take a landmark, which is the upper end of the sternum. So if you count 2, 3, 4, 5, 6, 7, 1, 2, 3. So the sternum is at the disc space between T3 and T4. So when you start counting at the thoracic spine, when that's available, so at least you have a landmark from where you can continue to measure the vertebral bodies accurately. Or what you can have is, you might have a CT scan. You can always look at that for the proper numbering. And the other thing that you normally look out for is that the first pair of ribs normally articulate with T1, unless there are cervical ribs. There are telltales to that. They're not very common. But another way to decide these things is to start counting the ribs from T1. Now, this is normally a person has 12 pairs of ribs. Some people can have 11 or 13. This is very uncommon. But if you're having problems, many people do have x-rays of the spine. If you go back to that, if you see the 12th pair of ribs, they articulate with T12. You start counting 1, 2, 3, 4, 5. Now, below 5, you see there's another vertebral body which seems to be separate from the sacrum. So you can see the sacral ala over here. And these are prominent transverse processes of the vertebral body at the lumbosacral junction. So this is therefore regarded as lumbarization of S1. So counting again, 1, 2, 3, 4, 5, and this is therefore an S1. This is another case. Again, you can see that you have x-rays. The last ribs, you presume them to be articulating with T12. Counting again, 1, 2, 3, 4. Now what has happened to 5? You can see that the 5 is fused with the sacrum. It's part of the sacral ala. So this is a case in which there is sacralization of L5. So x-rays can be very useful, and if they are available, it's always a good idea to have a look at them. Another landmark, which is very useful in almost about 98 to 99% of the cases, is the iliolumbar ligament. Now, this is a ligament which extends from the spinous process of L5 to the pelvic bone. And when you see this, you can almost certainly say that the vertebral body it is arising from is L5. The same ligament you can see on CT, so it extends from the transverse process of L5 towards the pelvic bone. And this is another MR in which, again, you can see this ligament extending from the transverse process towards the pelvic bone. So when you see this ligament, this is a very useful marker to tell you, yes, this is L5 vertebral body. Moving on to the MRI planes and sequences, a standard MR usually will have sagittal and axial images. for those centers which do things right, they usually have a T2 cornel as well. That's always a useful add-on, because sometimes your lateral discs can be missed on your sagittal and axials, and therefore it is a good idea to have at least one cornel T2. It can also help you assess scoliosis and other things if you don't have x-rays. Starting off the image on the left. So when the CSF is dark, that is a T1 weighted sequence. When you have the CSF, which is bright or hyper intense, if you want to use technical terms, so hyper intense CSF can be in a T2 weighted image or a stir. The difference between a stir and a T2 is that the fat remains hyper intense on T2, whereas it gets suppressed on the stir images. So you can see that the fat is appearing black, so subcutaneous fat, or even the fat in the marrow of the vertebral bodies. So this tells you that this is the stir sequence. This is a very sensitive sequence if you want to see inflammatory changes, be it in the cord or be it at the end plates or anywhere else. So this is one of the very sensitive sequences because it suppresses the fat, and therefore the signal you get after it suggests that there is inflammation or edema going on at that site. So apart from the 3 sagittal images, you'll have the 2 axial ones. Again, the CSF in the canal, it's bright, so this is a T2 weighted images, and this one, it's dark, so this is a T1 weighted image. Just a side note that one should not take this for granted, because some people say, oh, it's just dark, so we can't see the nerves within the canal. Yes, you are very right. But at the same time, you can see that there is fat around it. So sometimes if I'm equivocal on T2 weighted images of what's going on, I can always come back to T1, and especially the exiting nerves within the lateral recesses and foramina are quite nicely outlined on T1. So if you have any problems on T2, you know, there's a lot of degenerative changes, other stuff going on, go back and have a look at the T1. That fat around the nerves will help you outline the nerves. So going to the basic anatomy, centrally you have the nucleus pulposus, which is surrounded by the annulus fibrosus. So this is the vertebral body. You have the lamina, which come over there. Then you have the pars, and then the facet joints. Now you have to remember, anteriorly you have the superior articular process, and posteriorly you have the inferior articular process. So when you see a facet joint, what will lie anteriorly will be the superior articular process of the lower vertebral body, which is L5, and what will lie posteriorly is the inferior articular process of L4. Now, going on to things that are more concerning to you, this is the spinal canal. Some people use the term central canal. Well, that should not be used, because the central canal, if you remember the anatomy, is the central canal within the cord. So if I'm reporting a CT, I call it a vertebral canal because it's more about the bones. And if I'm talking in terms of MR of the spine, I will call this a spinal canal and not the central canal, which is an inappropriate term. Then you have the exiting nerve roots. So these are the nerve roots which are exiting, and you have the traversing nerve roots. So for example, you're looking at the level of L4, L5. So the nerve that is exiting will be L4, and the one which will be traversing is L5. So just remember, the exiting, if it's L4, L5, L4 will exit, L5 will traverse. And this is very important. Unfortunately, I see quite a few scans where there's a lot of talk about the degree of stenosis, you know, whether it be of the spinal canal or the lateral recess or the foramina, but often people don't talk in terms of the relationship of what the stenosis is doing to the nerves. Now, this is just as important or if not more important than just the degree of stenosis. You can have patients with big discs and stenosis where the nerves can often go unaffected. So it is important to chart the path of these nerves, especially if you're reporting or if you're having a look at these scans. So sagittal plane, so this was an axial. It's brilliant at looking at the spinal canal. It's excellent at looking at the lateral recesses. But if you want to look at the foramina, that's best looked at the parasagittal plane. So this is the exiting nerve, the vertebral body, the pedicle, and the keyhole sort of an appearance. So this keyhole appearance is the thing that is what you need to see. If it's preserved, that's good. when there is sort of mild stenosis, you can see part of the lower going, and as it goes moderate, the superior part gets encroached on, and severe, there's total loss of this keyhole appearance. So this is quite the best plane to look at anything which is happening in the foramina. Now, one has to realize that anatomy and terminology is important. You don't want to sound like a novice. And as a rule, the cervical and thoracic spine does not have the lateral recesses. When you talk about spinal anatomy in the cervical spine or the thoracic spine, you have the spinal canal and the exiting neural foramina. We do not talk about lateral recesses, and that's just an anatomical thing which sort of needs to be respected. And if you start using the term lateral recesses when it comes to the cervical spine or the thoracic spine, you'll only sound like a novice who's not sure about what he's talking about. So there are 4 levels at which the nerves can be compressed. This can happen at the level of the disc itself. It can happen at the level of the lateral recesses, the foramina, or they can be extraforaminal. So these are the 4 levels, and we will talk through this as I go on. Another thing is the most common thing that we're trying to address is usually disc morphology, because that's something that can be treated, and the herniation. In a normal scan, what happens is that the axial images, if you can see, they are taken quite parallel to the level through the disc. So rather than have a stack of continuous images, they take images at the level of the disc. So ideally, one will go through the inferior end plate, one will go through the level of the disc, and the other will go through the level of the superior end plate. And if nothing else, they will image at least from L3-L4 to L5-S1. If you have experienced technicians, they can always image any other levels where they think that there is a degree of stenosis. So the same thing, they'll go through L3-L4, L4-L5, and then L5-S1. You have to look at all the images, the sagittal and the axial, for the interpretation. Now, there are other things that we need to take into consideration as well. So one thing we talked about is herniated discs. So these are the nerves that are going. So a herniated disc itself can cause stenosis, but there are other things as well. So you have the facet joints. If you have facet arthropathy, which can result in hypertrophic changes, this can narrow the canal. You can have the ligamentum flavum. So hypertrophy ligamentum flavum itself can narrow the canal. And we'll go on later when we talk about these things. Just going on to basic appearances. So centrally, you have the nucleus pulposus surrounded by the annulus fibrosus. So you see the high signal nucleus pulposus surrounded by the dark signal annulus fibrosus. Now, this is an annulus fissure. You can see it transecting through the annulus fibrosus. And just a word of caution, normally the term that we should use is an annulus fissure. Many people use annular tear. There are connotations. When you say an annular tear, it suggests that it's post-traumatic, and this can have implication in people who play sports as well as in medical legal cases. So try to refrain from the term annular tear, because that is implying that it is usually traumatic, as opposed to an annulus fissure, which can be degenerative, which is most likely the case. Now, you can either have diffuse disc changes or focal disc herniations. So when the disc outflows the confines of the vertebral body, it is herniating. If it's done all around 360, so that's a diffuse disc bulge. It can be asymmetric, where it involves about 90 degrees or more than 25% of the vertebral body. Now, if the herniated disc is less than 25% or less than 90 degrees, then it has its own classification. You have protrusions and extrusions. A herniated disc is called a protrusion when the base of the disc is broader than the herniated disc itself. So you use the term protrusion. Extrusion is when the base is narrower than the width of the actual herniated disc. Having said that, if any disc migrates cranially or caudally, in either case, that does become an extrusion. So this is an example where the herniated disc has migrated cranially. So any migration of the disc automatically upgrades it to an extrusion, irrespective of whether the base is wide or not. In a sequestered disc, the disc loses its connection with the parent disc and lies separate from it. So that becomes a disc, a sequestered disc, as opposed to an extruded disc. Now, when you talk about disc herniations, you have to use the terminology. It could be central. The central discs aren't all that bad because you can see it's quite capacious in the central part of the canal, and you'll have to have a larger disc to actually cause nerve compression, as opposed to some people like to use the term paracentral, although the recommended term is subarticular. So if it's paracentral to one side, you can say, in this case, right subarticular disc protrusion. Then if it goes more laterally, it's the foraminal protrusion, and it could be extraforaminal or lateral. So whilst the descriptives are important, you need to mention whether it's central, subarticular, foraminal, or extraforaminal, and each have their own connotations. So that usually holds for the lumbar spine. But when we're discussing about the cervical spine, you more likely are going to encounter disc osteophyte complexes. So it's not just the discs alone, it's part of the osteophytes coming from the vertebral bodies. And you can see that we talked that the conical triangular top is C2. So at the level of C3-C4, the disc height is slightly reduced, and you have sort of a disc osteophyte complex. Go immediately to your axial images. You can see that it is sort of abutting the ventral aspect of the cord, and it is narrowing the exiting neural foramina. There's a much larger disc at 2, 3, 4, C5-C6. You can see there's another disc osteophyte complex. On the sagittal images, you can see that it is compressing the cord to the extent that there is signals change within the cord, suggesting that there is compressive myelomalacia that has started happening. And if you see the corresponding axial images, a much larger disc, it has flattened the thecal sac and the cord has been deformed. The exiting neural foramina have severe stenosis. Just to make it more evident, I'll just put up these two cases side by side. This is how it should normally look like. Sort of an anterior convexity of the vertebral body is preserved. You can see the cord. There is voluminous CSF around it, quite capacious. And these are the exiting neural foramina, which are quite ample. Going on to that same case, now you can sort of, when you see this, you can realize, oh, the canal, the thecal sac has been really flattened out, the cord has been compressed, and both the exiting neural foramina are severely narrowed. If you have a keen eye, you'll realize that normally the facet joints have good outlines, they're quite smooth. What's happening over here, irregular outlines, bulky looking. So this stenosis is further aggravated by facet arthropathy in this particular case. Now going back, the term disc protrusion. So at the level of L5-S1, you see that the disc height is reduced. The disc signal is tampered with because normally you have a bright signal and therefore the signal is reduced. So the signal intensity of the disc is reduced, the height is reduced, there is slight end plate irregularity, there are modic changes. I'll discuss those in a while. And you can see that there is a disc which is sort of extending backwards and it is uplifting the posterior longitudinal ligament. So you have a case in which now, there is slightly a bit of a debate. This could actually be called a disc extrusion because many people, when they're quantifying discs, they're just seeing the axial planes. What about the sagittal plane? In the sagittal plane, if the base is again narrower than the disc itself, so the same rules apply. So this potentially, if you go on this image, you can see that the base is narrower than the vertical height. So in ideal circumstances, this should be called a disc extrusion. And this is the reason why I've put it over here, just to highlight the fact that many people just see the axial images and call it a protrusion, whereas this is actually a disc extrusion because on the sagittal images, the base is narrower than the vertical height. Now going on to the modic changes. So this is a T1, T2, and stir. What do you see? There's a bright signal on T1, a bright signal on T2, which is suppressed on stir. What behaves like this? Fat. Now, modic changes can be type 1, 2, or 3. 1 are the acute inflammatory category. So inflammation has what? Fluid in it. It will follow fluid signals. Type 2, relatively old now. These are the most common. Fat developing. And then the chronic, sclerosis. So what is the signal of fluid on MR? It's low on T1, bright on T2. What's the signal of fat? Bright on T1, bright on T2. And sclerosis, basically calcification, low on T1, low on T2. So this is an example of modic type 1. It's low on T1, bright on T2. So it means this is acute. And this could suggest why the patient is having pain. Same patient, lower level, the end plate, bright on T1, bright on T2, bright on T1. And therefore, this is fat. And therefore, this is relatively long-standing. At the same time, incidentally, you can see this annulus fissure on the images. So again, another example of a protrusion in which the base is wider. Now, not all of them are central. This is left subarticular disc protrusion. You can see an annulus fissure. And what is happening? This is how the exiting nerve is entering on the right. You can see that the one exiting on the left has been slightly splayed. It's best to go and look at the sagittal images for this. But what is obvious is that the traversing nerve, so this is the traversing nerve, which is just contacting the disc on the right. What's happening on the left, it has been compressed in the lateral recess. So these subarticular discs usually compress the traversing nerves, whereas the more lateral, the foraminal disc usually compress on the exiting nerves. And another interesting thing is that this patient has an annulus fissure where it is compressing the disc. Even if this disc was not compressing the nerve, but was just coming in contact with the nerve, when you have an annulus fissure, sometimes what happens is that this secretes substances which irritate the nerve. So it can result in non-compressive radiculopathy. So it's just something to watch out that, yes, in this case, it's obviously compressed in the lateral recess. But if you have an annulus fissure, which is in contact with a nerve which might not be compressed, just the fact that there's an annulus fissure over there can cause nerve root irritation. Now, moving on to a disc extrusion. What did we talk about the disc extrusion? Basically, the disc is wider than the base, or in this case, it has caudally migrated. So any migration of any sorts is actually a disc extrusion. So if you see, when you take the cuts, there's going to be one through the superior end plate, then one through the disc, and then through the inferior end plate. So starting from the superior end plate, you can see the disc forming over here along the subarticular region, going at the level of the disc. Always look at the sagittal images to correlate. It looks quite diffuse. But once you go to the level of the inferior end plate, you see, oh, this part, this is not a nerve, this is part of the disc. So this is the disc, which you can see is extending into the lateral recess, and this is likely compressing one of the nerves. So that's all about disc herniations and how they result in stenosis and nerve compressions. And as you've realized from the talk, that it is not just quantifying the degree of stenosis of the spinal canal, the lateral recess and foramina, but you have to make statements about what impact they're having on the nerves themselves. What are the other causes that can result in stenosis or nerve compressions? Now, just a comparative thing. You can see this is the spinal canal. What can narrow the spinal canal? If you have hypertrophy of the ligamentum flavum, quite common. If you have facet arthropathy, results in hyperostosis, that can cause it. Often, facet arthrosis can be related to a synovial cyst. This synovial cyst can exacerbate and cause problems. And what's the other thing? Normally, you have a small amount of fat. the epidural fat. You can have things like epidural lipomatosis, where the fat is prolific and it is causing this bunching up of the cauda equina nerves or stenosis. Now, just making comparisons, you can see when I showed you even previously, normally a facet joint is relatively better outlined like this, but over here you can see it's overflowing. There's more low signals suggesting there are calcific changes. So there is a facet arthrosis, and you can see that this has resulted in severe narrowing of the lateral recess, whereas you don't obviously see a large disc, but the spinal canal and the lateral recesses are significantly narrowed, and there are two contributing factors. One is the facet arthrosis. What is the other thing? This low signal, this Y-shaped signal, is actually the ligamentum flavum. Often facet arthropathy and ligamentum flavum come together, and the two of this in association with a relatively small disc bulge is resulting in quite severe stenosis. So always look out for facet arthrosis and ligamentum flavum hypertrophy, which are quite common. And just to show you this, you'll probably appreciate this better on the CT. This is how the facet joints normally look like: good outlines, good margins. And what happens when you have facet arthrosis? Irregular outlines, lots of sclerosis, so loss of definition, flowing out from where you normally expect them. So I just showed you a CT because I thought you'd better appreciate all those findings on a CT, and then you can retrospectively apply it to the MR interpretation. Now, the other thing is, when you have facet arthrosis, this can be compounded by synovial cysts. Now, these synovial cysts, they can be projected anteromedially or anteriorly or posteriorly. You'd want rather want them going posteriorly because there are no nerves here, so unlikely to cause issues. But when you have these synovial cysts projecting anteriorly and anteromedially, you can see that it starts impinging on the canal itself and on the lateral recess. So these synovial cysts are notorious for causing compressions and stenosis. This is the same cyst which is seen in the sagittal plane. So, if you're just seeing this, you might be more challenged. Oh, what's a cyst doing over here? But always go back to the axial, look for facet degenerative changes, and any cyst over here is more often than not a synovial cyst related to facet degenerative changes. The other important thing to realize is fluid. If there is fluid within the facet joint, this leads to instability because this fluid sort of allows for movement at the facet joint. So when you're scanning, the degree of stenosis might not look that much, but in a more dynamic situation, translation can happen at the facet joints, which can compound the stenosis. So it's always good to mention whether there is fluid in the facet joint, because that can lead to instability and dynamic non-compressive radiculopathy. Epidural lipomatosis. Now, this is, and therefore, not all your T1 weighted sequences are useless. I always cast an eye because you should know what you're looking for. This is a normal T1 weighted sequence. What about this one? This is again a T1 weighted sequence because here the CSF is dark or hypointense. Here you can see there's proliferation of this hyperintense material both posteriorly and as you go lower down anteriorly as well, which is causing constosis. You can see that normally the lipomatosis. More axial images. You can see again, this is how the canal on an axial T1 should look: wide, spherical, and round. It has been crushed or reduced to a Y-shaped band because of all of this proliferation of fat in a case of epidural lipomatosis. And if one does not look at it, you can actually miss a very obvious cause of stenosis. What else can you have? If you look, in this case, there are pars defects, and that is resulting in spondylosis. So what will happen? You see, this is a normal keyhole appearance of the exiting neural foramen. When you have pars defects, the vertebral body has moved anteriorly over the one below, And what has happened to the exiting foramen? It's deformed. The nerve, if you go even more laterally, is getting compressed. So this is a case of spondylosis with compressive neuropathy. And this is another example of extraforaminal compression, in which you can see that the nerve, that the disc has is herniating more laterally and is resulting in compression of the exiting nerve. The other examples are that of metastasis. So you have vertebral bodies in which you see lesions, and what is happening with these lesions is that you have sort of retropulsion. The retropulsion associated with the Mets is causing narrowing of the canal. Not all vertebral body lesions are metastatic, and the most common lesion is the hemangiomas. So these usually contain fat, as I'm showing you in the images, T1 and T2 weighted images on both spherical lesions, which are bright, and these are therefore hemangiomas. Moving on, another case of discitis and end plate osteomyelitis. If you see the thoracic spine, what's happening? Edema signal low on T1, it's bright on T2. The disc space is altered. You have this fluid signal within it. It's causing end plate irregularity. As I said before, the stir images are the best to delineate these. So you have the fluid within the disc level, and you have irregularity of the disc, which is resulting in discitis and end plate osteomyelitis. And that's quite enough, I think, from my end for the talk. If there are any questions, you are more than welcome to ask. Thank you.
Thank you so much, Dr. Rayyan. Yes, that was a lot for everyone. Are there any questions? Anyone?
Just a comment. That's not a question, rather a comment. A very excellent presentation. Very well understood. और बहुत समझ आई. Thank you very much, Dr. Rayyan, for your time. Thank you very much. Excellent.
Thank you very much for your
Many
kind
concepts
comments.
are explained very simply. Very simple. Excellent.
Hello.
Sorry,
Hello?
it started breaking up. I couldn't hear the last comment.
Dr. Khalid, can you please repeat the last comment? I guess we have.
These images are now routinely taken stir images.
At our trust, it is standard policy
Can you
to
hear me?
take stir images. Previously, in many places, they didn't take the stir images, but we have been caught off guard in many cases. And after that, it's standard policy where I work. I work in more than one places, but in both the places, stir is done routinely. And I think it's almost across the board, at least in UK, most places are doing stir. There are places who don't do it, but I think the added value is quite significant.
Dr. Rayyan, thank you very much. Excellent talk. Actually, I think you try to make it quite simple for us, but still it's way above our knowledge and understanding. But it will be quite useful, and it will be more useful if we could get, with the recording and the slides and full presentation available. So at our own time, we can see it again and again to get a bit more versed with it. So if it is possible, thanks very much.
No issues. I have a recorded talk already because I was anticipating some turbulence today. I'll send the recorded talk. And I think, the best way to do these things is usually a workshop where you have live cases and people can, really look at those in a live situation. It really helps more. But definitely I'll forward the recorded talk.
One more question, Doctor. Eh, Do we have MRI finding? Do you see any finding but symptoms are there?
Sorry, my apologies.
Any
For
area which
some
is not
reason,
seen?
your voice was breaking up again, unfortunately. Sorry, could you repeat it again? I'm not sure if it's
I
only
will repeat.
problem at my
I will
end.
repeat. I will repeat. We see patients in rarely who have all the symptoms, but MRI is for situation. MRI does not fix some pathology.
I think it's true for both ways, really. Sometimes you don't have any symptoms, and sometimes you see a lot of changes on the MR. So you treat the patient, not the images. So you can have a lot of findings, and sometimes we are
Yes.
quite confused that despite seeing so much findings, the patient doesn't have symptoms. To the contrary, the patient might have symptoms, and yet you might
Yes.
not see things. There are subtleties, like I told you before,
Yes.
that sometimes minor things, like if an annulus fissure comes in contact with the nerve, it can cause non-compressive myelopathy. Or if you have facet arthrosis with fluid in it, which makes it slightly unstable, that in a dynamic situation can cause nerve compression. And the other thing is, many of such cases in this part of the world, when you can't find a cause, they actually do a dynamic MR, because sometimes you don't see things on a rest MR which are become quite evident on a dynamic MR, which is done with patient in motion. So that's the last resort. But even then, sometimes you can have cases in which you can't definitely identify something on imaging.
Thank you.
Dr. Rayyan, can you see the chat section? There's a question for you there.
Yeah, sure. I'll have a look at the chat. We just discussed MRI. What about X-rays and CT scans, especially in resource limited setups? In all fairness, it's not very useful. I mean, yes, X-rays can tell you some limited information. Maybe CT scan. The only time we do CT scan is when there's a contraindication to MR, and you might see bony changes, but in most of these cases, it's caused by soft tissues like discs and things like hypertrophy ligamenta flavum and whatnot. So I think it's slightly disservice to the patient, or it's really suboptimal if you go for X-rays or CT scan instead of an MR, because in all honesty, they will not even yield about, the MR will have 90% more information than a CT or an X-ray could ever offer you. So I think they're not alternatives to this. And I do understand resources can be limited. Patients might not have the money. But if you are to truly answer the relevant questions, you do need the scan, and that is the MR. CT, again, radiation with little output. So it's not something that I would truly recommend. There's no comparison. I hope that answers the question. Anything else?
Dr. Rayyan, I have two questions. Can you explain how you guys do the dynamic MRIs? And the second thing, as a pain physicians,
Thank you.
we do get
There
a
are no
lot
more
of
questions.
information.
Thank you to you.
So as a pain physician, we do get a lot of information on the MRI without contrast. So when we should get the MRI with contrast? So is there any particular situation that we should be aware of that that's a point we should get an MRI with contrast?
Thanks for the question, Zatik. I think the problem is dynamic MRs are done on specific scanners which are meant to scan the patient in a sitting and standing position. So you cannot usually do these on a static MR unless you have a trade-off where you do a scan with patient supine, then you do it flexed and then extended. But that's not really, that's sort of a trade-off which can be done on your usual scanners. But in all honesty, the dynamic MR scanners are usually built in a way in which the patient is scanned either in a sitting or standing position. You can only sort of, the only trade-off is by doing it in a flexion, normal supine and extension position if you have a normal MR scanner. And as for the second part of the question, contrast, we usually do not give contrast. In post-operative cases, it's very helpful because you have epidural fibrosis. If you want to differentiate between a disc, which could be residual or recurrent, versus epidural fibrosis, then yes, contrast is indicated, and that is the most common cause for indication of contrast. Apart from if you're suspecting infection or a tumor, people can give contrast in that, but the most common scenario is post-operative spine, where you want to differentiate between epidural fibrosis versus a residual/recurrent disc.
Thank you.
Most welcome.
Do we have any more questions? I guess then that's it. Thank you so much, Dr. Rayyan, for your time. I guess then we can end the session now. Is that okay?
Thank you.
Thank you so much.